So let's talk a little bit about hemodynamic monitoring. Before we start talking about the two devices that we're going to be using to perform hemodynamic monitoring, let's talk about the different pressures and some measurements related to hemodynamics that we'll talk about this week, and we'll mention throughout the term as well. Our first pressure is going to be our MAP, our mean arterial pressure. And as it states, it is the average pressure measured within your arterial system. Because think about your blood pressure. Your blood pressure is due to the arteries in your body. Patients who are experiencing low MAP, so think if the MAP is low, that means that the blood pressure is on average low. And the lower the MAP, the lower the blood pressure, which leads to decreased perfusion to the organs. And when we have decreased perfusion to the organs or decreased blood flow to the organs, think what happens to that tissue. That tissue starts to become ischemic and eventually it will become necrotic. And now we have true tissue death. Whereas if we have high MAP, increased periods of MAP, or on average higher blood pressures, the higher the blood pressures, the more damage that we're going to have to our heart as well as our brain. The higher pressure within those arteries indicates that that heart has to pump harder, and the harder that heart pumps, the more weaker that heart muscle can get, especially over an extended amount of time, as well as in patients who have higher blood pressures. We know that hypertension, as we'll talk about in a few weeks, is a big risk factor for stroke. So when patients experiencing high MAP, they are at an increased risk for stroke as well. Then we have our pulse pressure, and pulse pressure is essentially the difference between your systolic and diastolic blood pressures. It's expected that your pulse pressure will be high in the event that you are exercising or doing some type of exertion. That's going to be an expected increase. Additionally, in patients who have atherosclerosis or coronary artery disease, essentially, they too will have higher measurements of pulse pressure as well. Whereas pulse pressure is going to be low in patients who are hypovolemic, so not enough blood volume on board, as well as heart failure. Then we have our CVP, or central venous pressure. And this is the measurement of pressure within the heart, essentially telling you how much blood is going back to the heart. But I like to think of CVP as pressure within the heart. So CVP normally ranges between 2 and 6 millimeters per mercury. Going back real quick, your MAP normally ranges between 70 and 100 millimeters per mercury. No measurement that you need to know from pulse pressure. So MAP is 70 to 100. All right, going back to CVP. CVP normally ranges between 2 to 6. In the event that our patient needs their CVP measured, where inside the heart it is measured is actually at that right atria, superior vena cava area. So it measures that pressure inside the heart, but kind of right there at that right atria, superior vena cava entrance. In the essence that a patient is experiencing high CVP, so greater than 6. When they have high amounts of CVP, think high pressure, high CVP, high pressure in the heart, high fluid in the body. So these are going to be patients who are hypervolemic. They have heart failure. So think your heart failure patients, the more fluid that they're retaining, whether in the lungs or, as you'll see when it's coming from the right atria, the rest of the body, so the legs and the belly, that pressure is going to be high in patients who have heart failure. So high CVP is measured in patients who have heart failure, as well as patients who are in fluid volume overload. Then we have our patients who have low CVP. So low CVP, low pressure in heart, low fluid in the body. So patients who are hypovolemic. Those hypovolemic or severely dehydrated patients, they are going to be the ones who have a CVP less than 2 or probably right around 2, sometimes less than that. So low CVP means low pressure in the heart, low fluid in the body. High CVP means high pressure in the heart, high fluid in the body. Next, we have our cardiac output. And as we will talk about throughout this whole, term, cardiac output is going to be very, very important to understand. Cardiac output is necessary to ensure that the body is getting a proper amount of blood flow or ejection of blood from the heart to sustain perfusion of those organs. And with a patient who is experiencing decreases in cardiac output, that will ultimately lead to a drop in their blood pressure. And just like we talked about when we were mentioning about MAP, when our blood pressure drops, MAP drops, and that leads to decreased perfusion in the organs. So think decreased cardiac output leads to decreased blood pressure and ultimately decreased perfusion to the organs. Then we have our SVR, which is short for systemic vascular resistance. So now we're looking at the actual vessels in the body now. So think when we're talking SVR, we are talking about the vasculature, the vessels. And when it comes to SVR, we are going to be thinking in the terms of vasoconstriction and vasodilation. So low SVR. So think low SVR means low resistance in the vessels. So think if there is low resistance, think low means loose, wide open vessels. If a patient is experiencing low SVR or having low resistance, these vessels are wide open. In essence, they are vasodilated. Medications like morphine can cause a patient to experience a decrease in SVR, as well as our vasodilated medications like nitroglycerin. Any of our nitro-based drugs are vasodilating. So low SVR, low resistance, vasodilation, open vessels. Think too, when your vessels are wide open, think what happens to that blood pressure. Do we see? That blood pressure will drop. Another instance that we will see low SVR is in early septic shock. Okay, in early septic shock, our patients experience low SVR, massive vasodilation. Then we have high SVR. So think high SVR, high resistance, high, tight, constricted vessels. So with our high SVR, our patient is experiencing vasoconstriction at this point. So the vessels are tight. So this can be due to vasoconstricting medications like epinephrine is one of those medications. In patients who are hypovolemic. So think of the vasculature as like roots of a plant. And for a plant to thrive, those roots have to be well watered, be plump in essence. But if there's not enough water in those roots, what do those roots do? Become very tight and very dry. In essence, your vessels do the same thing. When there's not enough volume or fluid in the body, those vessels start to tighten up as a result of that drop in blood pressure. And those vessels become very, very tight and very vasoconstricted. And then we will see patients who are septic experience vasoconstriction in late septic shock. So as I just said before, early septic shock patients have low SVR. Late septic shock patients will end up having high SVR, high, tight vessels. All right. So we've been talking a little bit about hypovolemia and hypervolemia. So think of this, keep this in your mind right now. Hypovolemia patients, low volume, low pressure in the heart, low fluid in the body. So low CVP and high SVR. So hypovolemic patients will have low CVP and high SVR. Whereas your patients who are hypervolemic, what is that CV to? Hypervolemic, fluid volume overload, high pressure in the body. Okay, high pressure in the body. So we have two hemodynamic monitoring devices that we will be talking about this term to help us gather some information about that patient's severity of their heart and lung problems. So our first device is our PA catheter, short for pulmonary artery catheter, also officially called a Swan-Ganz catheter. So a PA catheter is a true central line. Any central line a patient has is going to terminate or end in the heart. So if you look at the picture, you will see here that the access for your PA catheter is going to be that internal jugular vein. And then that catheter gets threaded down into that superior vena cava, gets threaded through that right atrium, down into that right ventricle, exits the right ventricle, and it terminates and ends right there at that pulmonary artery. So it goes all the way through the heart. Anytime we have a line that is inside the heart muscle or going through the heart muscle, it is a necessity that our patient has a cardiac monitor on because we're in the heart. And anytime you're in the heart or messing with heart tissue, there is an increased risk of dysrhythmias. So any patient that has a pulmonary artery catheter must have a cardiac monitor on at all times. The types of patients that might get a PA catheter are going to be obviously patients you'll see it in the ICU who are very ill. You can see this in patients who experience acute respiratory distress syndrome, or ARDS for short, heart failure, your very severe heart failure patients, your shock patients, trauma patients, as well as our coronary artery bypass graft patients, post-surgery patients. Now, there are 4 lumens, 4 ports connected to this PA catheter, and we will recognize them by color. So first we have our blue lumen. Our blue lumen, if you look at the picture, sometimes referred to as our proximal port. So I like to think proximal means first, kind of further inward or higher up. So proximal port, our first port, our blue lumen, goes all the way down and it terminates in that right atria. So because it terminates in that right atria, that superior vena cava right atria area, we can use this lumen to measure CVP. Think about what we just said. What does CVP measure? CVP measures pressure within the heart, pressure in the body. Blue lumen can help us measure CVP. Because it's also ends in the right atria, it can help us measure the right atrial pressure, is what this RA stands for, is right atrial pressure. We also can fortunately use this port to give medications as well as fluids when needed. Our second lumen is going to be our white lumen or white port. And our white port is only used to give medications and fluids. And we like to use this port if we need to give large volume of fluid at one time. So this might be the port that we use for a patient who needs a few boluses. If we need to give a couple liters of fluid over a short amount of time, the white lumen is going to be preferred. Then we have our red lumen. And red lumen, I want you to think red lumen, red balloon is what it is. All right, red lumen, red balloon. The red lumen is only used when we need to use our yellow lumen. So our yellow lumen is the port that we use to measure PALP. And PALP is short for pulmonary artery wedge pressure. Okay, so we'll talk about PALP in just a moment, but let's go back over our lumens. Blue lumen is used to measure 2 pressures, CVP and right atrial pressure, and can be used for meds and fluids. White lumen, only used for meds and fluids. Red lumen, red balloon. And then yellow lumen is going to help us measure PALP. So what is PALP? PALP is short for pulmonary artery wedge pressure. And pulmonary artery wedge pressure is a measurement that measures pressure within the heart, pressure within the body. So it helps measure that left ventricular filling. So once again, pressure within the heart. If you see where it terminates, it ends at that pulmonary artery. So if we wanted to get our PALP measurement, what we have to do is inflate our red balloon. We inflate our red balloon. The catheter is hooked up to a transducer that is going to be used to measure our pressure. And then once we get our pressure measurement, we need to deflate that balloon. We only want to leave that balloon inflated for a short amount of time because think about where that balloon is located. It's in that pulmonary artery. What is past that red balloon? The lungs. Okay, so if we were to leave that balloon inflated for an extended amount of time, that means we are not getting blood flow to our lungs. So we only use the red lumen when we need to get a measurement of PALP. We inflate it briefly and it needs to be deflated. Now our PALP normally ranges between 6 and 15 millimeters per mercury. All right, so normally ranges between 6 and 15 millimeters per mercury. When we're measuring PALP, think once again, high PALP, high pressure in the heart, high fluid in the body. In the event that we have high PALP, High pop we are going to see in patients who have fluid overload. So what we're going to see in patients who have fluid overload, because we're measuring that left ventricular area, I think left means lung, left fluid overload, left heart failure. So what symptoms do you see with left-sided heart failure? You're going to have your crackles that you hear upon auscultation. That patient can have a cough that is productive of pink frothy sputum. They're going to be very short of breath because all that fluid is in the lungs. And they're going to be very tachypnic and potentially hypoxic. So when we have high pop, high pressure in the body, high fluid, high pressure in the heart, you're going to see those symptoms of fluid overload. Whereas in the event that we have low pop, low pressure in the heart, low fluid in the body, we are going to see symptoms of hypovolemia. What do our hypovolemia patients look like? They're essentially dehydrated. You're going to have the dry mucous membranes. You can have the poor skin turgor, the skin tinting. Patient might be a little bit pale sometimes if they're dehydrated. So we're going to look for those signs of hypovolemia, decreased urinary output once again. So high pop, high pressure in the heart, high fluid in the body. Low pop, low pressure in the heart, low fluid in the body. Now, because our PA catheter is a central line, that means it is an invasive procedure to be placed. It is an invasive procedure. So therefore, a provider will need to obtain consent as part of our pre-procedure preparation for a PA catheter. So provider needs to get consent, and then of course we witness it. And then positioning for this patient, we want to make sure that obviously they're going to be laying in the bed, probably 30 to 45 degrees for our provider. It is an absolute must that our patient be on cardiac monitoring while the PA catheter is being placed, and they will need to wear it the entire time that that PA catheter is in place. So a cardiac monitor must be on the entire time our patient is getting the PA catheter placed, as well as long as it is in place. Once the provider successfully places the PA catheter, a chest x-ray needs to be done post-procedure to ensure placement of that PA catheter is correct. Meaning the provider is going to be looking for it to make sure that that catheter went through the right atria, the right ventricle, and ended in that PA catheter, in that pulmonary artery, and did not move anywhere else. Care for our patient with the PA catheter. We want to make sure, as you see in this picture, this is what our transducer, also known as stopcock, is referred to. And we want to make sure that our stopcock is level with that patient's right atria. So that way we can get an accurate measurement of our pressure. So we want to make sure that that patient's chest is level with the stopcock. That right atria is level with that stopcock. You also want to be mindful of the line when that patient gets turned or when they're moving to ensure that it has not been dislodged or anything. Now, how to actually use the PA catheter measuring device, that is going to be more detailed than you need to know. That's going to be something that's going to be taught to you on the unit if you go into critical care. But big thing from it, I just want you to know, is positioning. You want to make sure that that patient remains level with that stopcock. Because this is a central line, we want to make sure we do our normal central line care for this patient, that we assess that dressing for any signs of infection, that you change it per hospital protocol, which could be every 7 days. Anytime we're accessing that PA catheter, we want to make sure that we scrub the hub. And then when it's time to discharge the PA catheter, because it is an invasive line that was placed, we want to get a DC order from that provider. And then our final hemodynamic monitoring line is our arterial line. And an arterial line is only used for two things. We can use it to measure a patient's intra-arterial blood pressure, and we can use it to gather arterial blood in the event that we need an ABG. We cannot use an arterial line for medication administration. We cannot use it for IV fluid administration. We can't even use it to get blood for like our daily labs, like a CBC or a blood glucose or a BMP. We cannot use an arterial line for that because it is going to draw arterial blood. All the labs that you are getting, with the exception of an ABG, needs to be venous blood. So we cannot use our art line for medication administration, IV fluid administration, nor blood draws. We can only use it to measure intra-arterial blood pressure and to get arterial blood for an ABG. Now, this is an invasive procedure, so once again, consent will probably need to be got prior to this line being placed. Now, your access for your arterial line, majority of the time, your access is going to be that radial artery. Before accessing that radial artery, there is an assessment technique that should be done prior to placement of this line, and that is going to be your Allen's test. Think all the way back to physical assessment where we discussed the Allen's test. The Allen's test is done to ensure that the hand will have adequate blood flow if that radial artery becomes compromised. So to perform that Allen's test, that is where you're going to take your patient's hand, you're going to put one thumb on the radial artery, and you're going to put your other thumb on the ulnar artery. And you're going to press down on both arteries at the same time. You're going to instruct your patient, if they are able to, open and close their hands a few times. And what you will see is your patient's hand go from pink to pale. After they've opened and closed their hands a few times and our hand is pale, you're going to let go of the thumb that is holding down that ulnar artery. So you keep your thumb on the radial artery, but you let go of the thumb on the ulnar artery. When you let go of the thumb that's on the ulnar artery, what you want to see is that this hand goes from pale to pink. Right? When you let go of the thumb on the ulnar artery, you want to see that hand go from pale to pink. If the hand goes from pale to pink with that radial artery not being pressed, that indicates that that ulnar artery is patent enough to supply blood flow to that hand if something were to happen to that radial artery. Now, if we let go of the ulnar artery and that hand remains pale, that indicates that that ulnar artery is not patent enough to sustain blood flow to the rest of the hand. Therefore, that artery, that hand, should not be used to have an arterial line placed. So an Allen's test must be done prior to placement to ensure that that ulnar artery is able to provide adequate blood flow to that hand if the radial artery is compromised. Now, radial artery is not sufficient enough. You can see it sometimes placed brachially, and once in a blue moon, you might see it placed femorally. But majority of the time, you're going to see it placed in the radial artery. The provider places it, and the catheter that you see, it almost looks exactly like an IV catheter that you would be placing for a patient who's going to be getting IV fluids or medications. Looks just like that. But remember, once again, we do not use it for fluids or medications or to get daily blood draws. So once that catheter is in place, the arterial line is hooked up to a pressure bag that we can use to measure our patient's intra-arterial blood pressure. With this line in place, it's going to have a dressing over it, almost like a tegaderm over it to keep it secure. This patient needs to be wearing continuous cardiac monitoring and SpO2 monitoring, just like our patients have a PA catheter. We want to make sure that we do neurovascular checks for this patient. We're going to do hourly neurovascular checks for these patients and make sure that we're documenting them. Remember, your neurovascular checks are going to be assessing the temperature of that hand, the color, the sensation, capillary refill of that hand, as well as making sure that that line that does not look like our line is occluded or anything. If our patient's hand becomes cool or pale, or that patient starts to report pain or some paresthesias in that hand, that can be a sign that there is a clot has occurred and is blocking off blood flow to the rest of that hand. So we want to notify our provider immediately if that occurs. And then we do have to worry about infection because it is a line. Anytime we have a line going into the body, there always is an entryway or an open source of infection for the patient. So we want to monitor for signs of infection. And then we do have to worry about bleeding. So what would you do if your arterial line gets yanked out of your patient's wrist What are you going to do? What's going to happen? Well, what's going to happen is radial arterial blood is going to start spurting out of your patient's hands. So we immediately need to hold pressure because this is arterial bleeding. So we're going to hold pressure immediately and call for help if an arterial line gets pulled out. Okay. So if an arterial line gets pulled out, we want to hold pressure immediately and call for help. And then once again, just to reiterate, arterial line is not used for any type of blood draws, like for your regular daily labs. We can only use it to get blood for ABGs. If your patient has an arterial line and they're going to be getting frequent ABGs, we can get the blood. Us as the nurse can get blood from the arterial line for the ABG. The respiratory therapist doesn't have to keep sticking that patient if we have an arterial line in place. And we can use an arterial line to get a more accurate blood pressure within the body, and that's measure our intra-arterial blood pressure. All right. So those are our two hemodynamic monitoring lines. And we talked about our several different pressures, our CVP, our pulp, our cardiac output, and the such. So that is your brief, or I shouldn't say brief, that is your lecture over hemodynamic monitoring. Thank you.